All right, guys, we're going to talk about pain. So I want to start from the bottom up and work towards the big overarching idea of what pain is. I like to use the example, and if you've been in the clinic, you've heard this before, of a guy walks up to you and sticks a knife in your leg, because it's a really clear case of actual tissue damage. So you have this knife in your leg, you don't feel pain in your leg. Initially, what you experience is the slow conducting nerve fibers that detect chemical temperature or mechanical change, and they're shooting these signals up to your spinal cord and then up to your brain saying, hey, pay attention to me. And these signals are not pain signals. What they're doing is they're acting like fire alarms. So a fire alarm in your house doesn't tell you there's a fire. A fire alarm in your house gets your attention so you can go out and check and see what's going on, right? It could be steam coming out of the bathroom. It could be smoke coming off the stove. It could be that somebody actually lit a fire in your house, but the fire alarm going off does not tell you that. You have to go figure it out. So you get these fire alarm signals going up to your spinal cord and then to your brain, and then every other sensory input you're experiencing also comes into play. So what you're seeing, what you're hearing, proprioceptive information about like your balance, how much load you're under, how fast you're moving, various other sensory inputs, tactile input from your skin, all these other things. And your brain starts mushing this all together. So in the case of the knife in your leg, you would look down and you get the visual input of, hey, there's a knife stuck in my leg. You get the auditory input of the guy yelling, ha ha, I stuck a knife in your leg. You get the tactile input of blood running down your leg. You get the nociceptive input, the alert signal input of a mechanical change to the tissues. And within a few minutes to a few hours, you get another nociceptive input of a chemical change when the inflammatory response starts coming in and lets you know that tissue healing is starting to occur. And so your brain is getting all these signals, but it can't decide whether or not to experience pain based just off the sensory inputs and the nociception. And so it needs to put these things in the context of the situation. So if you've ever seen like a 2-year-old running around and they fall down and smack their face on the floor, they get up, blood's dripping down their forehead. They don't cry right away most of the time. First, they look at mom or dad. And if mom or dad say, oh no, that's the worst thing I've ever seen. Oh gosh, you're bleeding everywhere. Oh, this is terrible. We're going to the hospital. The kid starts crying, right? If the kid gets up, blood dripping down their face, and mom and dad say, oh, you're fine, it's fine, wipe it off, rub some dirt in it, ha, that was funny. The kid gets up, blood dripping down their face, runs off laughing, keeps playing, spatters blood everywhere. It's awesome. So you can have the exact same sensory inputs. The kid fell down, he got the visual input of the ground rushing up at him, he got the mechanical change to the forehead when it hit the ground. He got the nociceptive input from the inflammatory response as tissue healing started to occur, all these things, but depending on the context that mom and dad gives him, he experiences a very different overall sensation. So as adults, we have a lifetime of context built up. We don't necessarily need someone else to tell us, but we do still look to experts to get some of that context. We look to physicians, we look to physical therapists, we look to Google most of the time, right? You say like, hey, my knee hurts, and you Google knee pain in the side of my knee, what is this? And it tells you it's cancer every single time. So what can happen is you're getting these sensory inputs, and then depending on the context that these sensory inputs are put into, you may experience more or less pain. If you have lateral knee pain on the side of your knee, and you Google and it says cancer, you're more likely to experience a higher level of pain than if you Google it and it says, you scratched your knee on a twig or something, which Google probably wouldn't say. So basically what's happening here is your brain is taking those sensory inputs, it's taking the context, it's mushing them together, and it's creating this big amalgamation of information, and it's asking the question, based on all of this stuff, is there a threat to my body based on everything it's gathered? And if your brain decides there is a threat, it creates the emotion of pain in order to make you deal with that threat. So what it boils down to is that all pain, no matter what kind of pain it is an emotion produced by the brain in response to what it believes to be a threat to the body based on the evidence it's gathered about the body and based on the context that has put that evidence in. And so this explains a lot of the variability in pain. So we see on MRIs and X-rays and all this other imaging that tissue damage or tissue changes don't necessarily correlate well with pain. Some people have a herniated disc and they're in very severe pain and need surgery. Some people have giant disc herniations and have no symptoms whatsoever. And it's because the brain is deciding to place these sensory inputs, maybe the sensory inputs are the same in different contexts. Maybe the brain is less worried about the back in one individual. Maybe that person's been deadlifting a long time and things are very strong. Maybe someone is more prone to just being very high strung and catastrophizing and worrying about things a lot, and they might be more prone to experiencing pain. So, and it's not necessarily a conscious decision either. Like there are conscious inputs into it. Being afraid of a movement can negatively influence. That's a negative context. that sensory inputs go into that can make you more likely to experience pain. But this isn't to say that pain is just necessarily something that you've decided to be in. Pain is technically always all in your brain. That's why I use the knife in the leg example. But it's not necessarily something that you're consciously deciding to do, and parts of it may be a little bit out of your control. Although over time we can always influence it through loading and kind of trying to desensitize the brain. So what do we do about pain? We first, we don't want to push into very, very high levels of pain, right? So pain is still useful. It's meant to protect your body. We have it for a reason. There are people that are born that have genetic conditions that don't experience pain, and they tend to experience very severe injuries through their lives and not do very well. They'll like accidentally bite pieces of their tongue off. They'll do stuff like that. Some people like bite their fingers off because they don't have pain. They don't experience it. And so pain is meant to keep us from damaging our bodies. But the longer you're in pain for, and as tissues heal up, the less likely it is to be associated with actual tissue damage. And so what can happen is, say you were in a car wreck 20 years ago, and you got some whiplash and like things moved really fast, and like maybe you herniated a disc, maybe just you were bruised up all over, things were very painful. The context of the situation the car wreck was in is very negative, right? Your adrenaline spikes, you're like, oh man, I'm gonna have to pay a bunch of money for my car, it got destroyed, my back hurts, all these things. And so you put this situation in very negative context, and then what will happen is a large percentage of people will continue to have pain for years after that, even though the tissue damage resolves fairly quickly. And that's, if it is a herniated disc, they tend to heal within a few months almost all the time. And so when your brain experiences a very significant traumatic thing like that, it leaves a big imprint on your brain. Just like when you study for a test, the more you study the test material, the better you get at the test material. The more you're in pain, or the more significant something happens in your life, such as a car wreck, the more likely it is to stick in your brain and really teach your brain a lesson and say, like, this stress that we just experienced is a threat. So next time, if in the car wreck you jolted really hard forward and you rounded your back really hard in the car and you experienced like a muscle strain and ended up in pain, a year or two later, if you round your back down, you just go to pick up your shoe, your brain remembers, hey, the last time we were in this situation, the last time I put stress through my back like this was a very bad thing. I was in a car wreck. And so I'm going to create pain before we get to the level of physical stress that we were in order to try and protect the back from damage before it gets to that point. And so if physical damage is right here, if actual tissue damage is right here, we want pain to be right here. We want the amount of physical stress we experience not to create pain until we get pretty close to that pain point, and then it stops us from our brain decides, okay, that's a threat, and we don't experience actual tissue damage. What can happen when you're in pain for a long time is that threshold starts dropping on down. And so all this right here can't create tissue damage, but our brain is interpreting it as a threat because it's so sensitive to very specific movements or very specific stresses through the body. And so then what happens too is, if we're not physically stressing ourselves up to here where that tissue damage occurred, now that tissue damage drops down because our bodies become less resilient, and now there's less space, and so that threshold keeps dropping down, and then the tissue damage threshold follows. And so you become weaker and you become more painful with simple movements like laying in bed. Laying in bed can't damage your back, or bending over to tie your shoes, that kind of thing. So the way we get out of this, and probably the most effective way to get out of this, is really just through graded exercise, graded exposure. So on day one, you can't, if you want to make your back strong, if you have low back pain, you're not going to come in and max out your deadlift on day one. Like that's, if you're afraid of tarantulas, you don't walk into a zoo and grab a tarantula and put it on your face on day one, right? Like you're not going to respond well to that. But if you come in and you do some of the stuff we prescribe, like Jefferson curls, and you start with a really light deadlift and you slowly progress up over time, that tissue capacity starts increasing, where the actual tissue damage will occur starts going up. And then your threshold for where your brain decides something is threatening starts going up as well, and eventually you can get close to that normal area again and not experience pain anymore. So it's really important too to keep in mind things that may make your pain worse. So somebody telling you, if you do this, you're going to need a hip replacement. If you do this, you're going to herniate a disc. Culturally, we're just afraid of rounding our backs. And so when you hear words like that, it creates that negative context, and you are more likely to experience pain with that. And so just keep in mind, like, our bodies are made to move. That's our whole name, right? And so if you just load appropriately and you move appropriately, you're much less likely to experience pain over time.